Abnormal liver function tests. Case. Dear Dr. Kat Beaumont, aged 50 years. Thank you for seeing this woman who has recently been diagnosed as having diabetes. She has a history of long-standing obesity and more recently of high cholesterol, 6.5 mol/L. Prior to starting her on simvastatin, I noted slightly deranged liver function tests: alanine transaminase 85 U/L, normal range 540, gamma-glutamyltransferase 150 U/L, normal range 735, which have remained abnormal on repeat testing. Physical examination is unrevealing. I would value your opinion as to the cause of these abnormalities. Yours sincerely. Introduction. Reduced liver function is hard to detect clinically, except when the liver is severely impaired. The liver can be markedly damaged without any overt clinical manifestation. The standard liver function tests can provide early warning of potentially serious pathology, but significant liver disease, including cirrhosis, can be present with normal liver enzymes. The detection of liver disease relies on the combination of careful clinical assessment, a variety of blood tests, radiological investigations, and often on histological examination of a liver biopsy. NB. Significant liver damage, including cirrhosis, may exist with little or no change in serum liver enzyme levels. NB. Interpretation of liver function tests. A normal GGT essentially excludes the liver as the source of a raised alkaline phosphatase. Reduced serum albumin is part of the acute phase response, hence levels may be reduced in severe infection even if hepatic function is otherwise normal. Prolongation of the prothrombin time may not be due to hepatic synthetic dysfunction, it can be prolonged by vitamin K deficiency resulting from prolonged cholestasis and malabsorption of fat-soluble vitamins. Liver function tests and their significance. Transaminases. Raised serum ALT and AST usually signify hepatocellular damage, but consider other source of AST, heart and skeletal muscle, kidney, red cells. Extreme elevations of AST and ALT occur mainly with drug toxicity, acute viral hepatitis and ischemic damage to the liver. Moderate elevations of AST and ALT are seen in alcohol-related, autoimmune, chronic viral, and other acute and chronic liver disease. Alkaline phosphatase and GGT. These biliary enzymes usually indicate cholestatic liver disease or biliary tract disease. GGT levels are disproportionately raised in alcohol-related liver disease, or where an enzyme-inducing drug such as phenytoin or phenobarbital is used. Segmental non-obstructive damage to the biliary tree, as in metastatic or infiltrative disease, often produces elevated biliary enzymes, mildly elevated transaminases and normal serum bilirubin. Alkaline phosphatase can arise from liver, bone, and intestine. Determination of isoenzymes can be used to distinguish between these sources. Bilirubin. Where hyperbilirubinemia is due to excess heme breakdown, serum bilirubin is predominantly unconjugated. Unconjugated bilirubinemia also occurs with inherited disorders of bilirubin conjugation, Gilbert's and Crigler-Najjar syndromes. Conjugated bilirubinemia can occur with any form of liver damage that interferes with hepatocyte function, intrahepatic cholestasis, but in chronic liver disease is typically a late feature and usually signifies hepatic decompensation. Primary diseases of bile canaliculi, ducts, and the gallbladder and large bile ducts, PBC, PSC, stones, produce hyperbilirubinemia and elevated biliary enzymes. Albumin. Albumin is produced in the liver and synthesis declines with worsening liver function. As the half-life of serum albumin is about 30 days, it is days before changes in synthesis are detectable. Prothrombin time. This is a sensitive test of hepatic synthetic capacity as the liver is responsible for the synthesis of factors 2, prothrombin, 5, 7 and 9. The prothrombin time responds rapidly to changes in hepatic synthesis as the serum half-life of clotting factors is of the order of hours. History of the presenting problem. It is very common for minor abnormalities in liver function to be uncovered by routine screening, particularly prior to initiation of new drugs. Many patients will have no specific symptoms, but ask about general malaise, tiredness, weight loss or gain, loss of libido and sexual potency, in men, and write hypochondrial pain or discomfort. Other relevant history. In inquiring about relevant history, bear in mind the commoner causes of liver enzyme abnormalities: fatty liver, steatosis, alcohol, hepatitis C, and the well-described risk factors for liver disease: previous blood transfusion, previous intravenous drug abuse, diabetes, medication use. Although the history-taking station of PACES is not primarily designed to test communication skills, some of the matters that need to be discussed are potentially sensitive, and the examiners, and patients in routine clinical practice, will not be impressed if they are handled in a brutal manner. This woman has diabetes mellitus, obesity, and hyperlipidemia, which are all associated with hepatic steatosis, but in addition to these important risk factors there may be other reasons why the woman may have abnormal liver function tests. Ask about the following. Previous liver disease or jaundice: has the woman had any problem with her liver or with jaundice before? Chronic viral hepatitis may follow a poorly remembered episode of jaundice, and recurrent episodes of jaundice may signify cholelithiasis. If the only abnormality is mild hyperbilirubinemia, consider Gilbert's syndrome. Alcohol, the most common cause of liver disease in the Western world. Even moderate intake may cause liver damage in susceptible individuals. Be aware of a tendency to minimize drinking when the patient perceives it as morally or socially awkward to be accurate. Drugs and medications: prescription drugs, oral contraceptive pill, over-the-counter medications, herbal remedies, traditional medications, and recreational drugs should all be considered. Also ask about surgery. Recent exposure to anesthetic agents may have provoked hepatitis, and gastrointestinal surgery for obesity may provoke a steatopatitis. Disease associations: diseases such as primary biliary cirrhosis, primary sclerosing cholangitis and other autoimmune liver diseases are not infrequently associated with other conditions. Ask about celiac disease, inflammatory bowel disease, thyroid disease, and autoimmune rheumatic disorders, e.g. scleroderma, Sjogren's syndrome, Raynaud's disease. Multi-system disorders: sarcoidosis and various vasculitides can all involve the liver, as may lymphoma and other neoplastic diseases, and infections such as tuberculosis. Infections: inquire about travel to or residence in areas endemic for hydatid disease, amoebiasis, schistosomiasis, and liver flukes. A patient may not regard it as relevant that he or she lived in India for 20 years, and the surrogate in PACES may be told not to mention it unless asked directly. Family history: ask particularly about a family history of liver disease, inflammatory bowel disease, celiac disease, hyperlipidemia, and diabetes mellitus, which this woman has. Each of these can be familial and associated with liver abnormalities. Exceedingly unlikely in a patient of this age, but in a younger patient with unexplained liver disease it is important to consider Wilson's disease and take a neurological and psychiatric history. About 40% of patients with this condition present with liver disease, but in others the first symptoms are either neurological or psychiatric or both, and include tremor, rigidity, drooling, difficulty with speech, abrupt personality change, grossly inappropriate behavior and an inexplicable deterioration in schoolwork, neurosis, or psychosis. Relevant in a younger woman might be pregnancy, which is associated with a number of hepatic disorders, including cholestasis of pregnancy, HELLP syndrome, hemolysis, elevated liver enzyme levels and a low platelet count, and acute fatty liver of pregnancy. Plan for investigation and management. After explaining to the patient that under normal clinical circumstances you would examine her to confirm her GP's findings, you would plan as follows. Blood tests. There are a large number of causes of abnormal liver function tests. The commonest causes of chronic liver disease should always be looked for, including hepatitis B and C, hemochromatosis and autoimmune liver disease, with others depending on clinical suspicion if the diagnosis remains elusive. Imaging. The first-line imaging test should be an abdominal ultrasound scan to look at the liver. Is it large? Are there abnormal areas? Does it look fatty? Are its blood vessels normal? The gallbladder, is there evidence of gallstones? And spleen, is it large? Liver biopsy. Sometimes the information from blood tests and ultrasound examination is not enough to make a confident diagnosis, or the degree of liver damage needs to be more thoroughly assessed in order to stage disease, assess prognosis, and guide therapy, in which case a liver biopsy may be indicated. Fig. 8. Management. Management will be dictated by the specific diagnosis made. Non-alcoholic fatty liver disease. Non-alcoholic fatty liver disease, NAFLD, is probably the most common liver disease in the developed world. It consists of two stages, fatty liver and non-alcoholic steatohepatitis, NASH, and a liver biopsy is needed to distinguish between them. A fatty liver is generally considered a benign and reversible condition characterized by fat deposits in hepatocytes. NASH describes the progression of fat deposition to inflammation or so-called steatohepatitis, which can lead to fibrosis, cirrhosis, and the associated risks of end-stage liver disease, portal hypertension, hepatocellular carcinoma. The combination of obesity, hyperinsulinemia, insulin resistance, diabetes, hypertriglyceridemia, and hypertension is known as the metabolic syndrome. NAFLD appears to be the liver component of this syndrome. Treatment of patients with NAFLD is still typically focused on the management of associated conditions such as obesity, diabetes mellitus, hyperlipidemia, and discontinuation of hepatotoxic drugs known to produce NAFLD, steroids, amiodarone, tamoxifen, methotrexate. There are no specific therapies. The use of liver biopsy in diagnosing steatohepatitis is still controversial, but clinical indicators predicting the diagnosis of the steatohepatitic subset include BMI greater than 30, being diabetic, and age over 45 years. Diagnostic blood tests for chronic liver disease. Alcohol-induced liver disease may be a raised IgA level, relatively higher AST than ALT, and disproportionately raised GGT. Fatty liver, hepatic steatosis, and non-alcoholic steatohepatitis. Associated with diabetes mellitus, so check fasting glucose and glucose tolerance test in patient without known diabetes. Chronic viral hepatitis. HBsAg is the correct screening test. If positive, test for HBeAg, HBV DNA. Note that antibodies to hepatitis B antigens may reflect previous infection or immunization. Anti-HCV antibody is the correct screening test. If positive, test for HCV RNA. Genetic hemochromatosis. Raised serum iron, transferrin saturation, and ferritin levels. Genetic testing for the common HFE mutation may be helpful, positive in 95% of affected individuals. Autoimmune liver disease. Raised IgG levels, positive autoantibodies, anti-nuclear, anti-smooth muscle, anti-liver and kidney microsomal antigens. Primary biliary cirrhosis. Positive anti-mitochondrial antibody. Alpha-1 antitrypsin deficiency. Reduced circulating alpha-1 antitrypsin, mutant form of protein on electrophoresis. Wilson's disease. Raised serum copper, lowered serum ceruloplasmin level, and increased urinary copper excretion basally and after oral penicillamine challenge. Note that in some cases acute viral hepatitis can be subclinical, so check IgM to hepatitis A, E or B antigens if there is possible exposure.